Well, a very good morning to you all, ladies and gentlemen. It's really nice to see so many familiar faces here this morning. I'm Dr. David Bull. I am the Deputy Leader of Reform UK. And I have to tell you, this is a major national crisis. As a doctor, I actually never thought I would witness the NHS in such a catastrophic state. You can ask any clinician, they will all say the same thing. It is, quite frankly, on life support, and it urgently needs resuscitation. In fact, it is in the resus room, but nobody has actually called the crash team. So it is lying there and no one is doing anything about it. And I think it's simply not good enough that the two main parties are talking a great game but actually delivering nothing. Staff morale, it's at an all-time low now. It's at rock bottom. Patient care is very patchy, it's inconsistent, and sometimes, quite frankly, it's downright dangerous. And public satisfaction with the NHS is now at an all-time low. Let me give you some figures just to explain what I mean. We have over 8 million people now waiting for elective procedures. We actually think that is wrong. We think it's more like 10 or 11 million people waiting for elective procedures. We have an almost total collapse now, a total collapse of accident and emergency. And they are not my words, they're the words of Dr. Adrian Boyle, who is the head of the Royal College of Emergency Medicine. In 2021, in last year, over 1 million patients waited more than 12 hours in A&E. That is disgraceful. There is an obligation to see people within 4 hours, so you have to be treated, admitted and discharged within that time period of 4 hours. We are woefully adrift from that target. 15,000 patients have been stuck in ambulances outside hospitals for more than 3 hours. And we know that because we see all the queues of ambulances outside hospitals. And any doctors in here will know if you can't get the patients out of the ambulances, then the ambulances can't move. If you can't get the patients into the hospital, then you can't get throughput. So those ambulances can't then be redispatched. In fact, looking at the figures generally, we've lost 25% of our ambulance capacity as a result of them all being in the car parks outside the hospital. I think the most frightening figure for me is that the wait, if you have a myocardial infarction, if you have a heart attack, you need to be seen really, really quickly. You wait now in an accident emergency department for over an hour. That is called the golden hour. If you wait that long, the chances are you will not have a very good outcome. And we've seen in the figures that people are dying because they're not getting prompt care. Preventable mortality is now running at 500 deaths a week, something I never thought I would see. And of course, as we know, there are crippling waves of strikes, the nurses' strikes on the 15th and the 20th of December, and other strikes as well. And fascinatingly, people are voting with their feet. So I've just looked at the latest Scottish figures. There has been an uplift in the number of people going to private care of 84% because they simply do not trust the NHS to provide the care that they need. So let's look at staffing. More than 40,000 nurses have left the NHS in the last year. By 2030, we will lose the equivalent of 8,800 full-time GPs, and in 10 years, 25%, a quarter of the population, could be without a doctor. We are short currently of 12,000 hospital doctors, we're short of 50,000 nurses and midwives, and another staggering statistic, 25% of new medical graduates coming out of university will actually leave after 1 year, so we're not retaining them. And then at the other end, 10% of GPs and consultants are planning to leave in the next 18 months for a variety of reasons. This is a national emergency, it's a national crisis, and instead of talking, we actually need to do something and to have a cogent, coherent plan. And I'm delighted that I can welcome Richard Tice, the leader of Reform UK, to outline that cogent, coherent plan.
Thank you very much indeed, David, and a very good morning to one and all. David has set out some of the challenges that we have got. We all know that I think in our lifetime we've never ever seen or experienced healthcare in such a crisis. And as David touched on, actually the crisis is even worse than we are being told. Because we think that waiting lists are at around 7 million people. But I'm going to read you a quote from a GP that explains why actually it's far, far worse. GPs are now effectively blocked from referring patients to hospital consultants in the traditional way. So if a GP knows that their patient needs an MRI scan, historically they used to be able to phone up a consultant and book it. Now they have to send them to a physio on a physio pathway, which takes weeks. And if the GP knew that that was the requirement for a MRI scan, the physio pathway won't work. Then the physio says, you need an MRI scan. But they're not allowed to get it. So they have to go to a super physio pathway. At the end of which, weeks later, they're told, you need an MRI scan. So what might take months, literally, to get an MRI scan, would have taken, in France, 2 to 3 days. So we've actually got no idea how many millions of people are stuck in the waiting list to join the waiting list. What we do know is the official waiting list is 7 million and rising. There are multiple crises all over social care and healthcare. And we hear from everyone that there's a staffing crisis. And there clearly is, in both departments. Hard to know exactly how much, but it's, give or take, it's 200,000 plus shortfall across both health and social care. Ambulance crisis with record long waits. We've got strikes literally happening in front of our eyes. Unknown to us. Nurses going on strike. Confidence amongst frontline workers at record lows. Confidence amongst the population at record lows. David touched on this issue of the excess deaths. What is going on that some 500 a week excess deaths above the 5-year average is happening? And yet, no one's talking about it. Where's the health secretary talking about it? Where's the chief exec of the NHS explaining about it? If you go back to COVID years, every day there was a press conference because people were worried about excess deaths. Could it be that there is a culture of cover-up which is endemic in the NHS? We know there is a major, major crisis. And yet, there are no bold solutions whatsoever coming from the mainstream parties. The truth is, the blunt truth that they won't tell us, is that we now have a national health emergency. It is, sadly, as bad as that. Now, what we need is a big, bold proposal that will make a difference. We have to say, we have to be ambitious. We have to say, we need to get to 0 waiting lists in 2 years. Most countries in the West don't have long waiting lists. Sure, you might say that's impossible. Why is it impossible? Other countries don't have it. So yes, it's a challenging target. But if other countries can do it, why can't we achieve it? A national health emergency requires a national endeavour and bold, bold action. And we need more staff. Now, Sir Keir Starmer this morning talked about the need for more staff, more training. And of course, in the medium term, that's right, but it takes time. It takes years to train more staff. We haven't got time. The crisis is now. We've got to retain existing staff. David talked about the concerns about nurses leaving every year. And we've got to attract former trained, experienced staff to come back into healthcare and social care, either part-time or full-time. But there needs to be a reason to do that. And bluntly, money talks. We've got people on strike because they feel that there's a cost of living crisis and the money doesn't justify with all the tax they're being tasked. So what we're saying is, right, we'll have a big proposal. All frontline, patient-facing healthcare staff and social care staff would pay for 3 years 0, I repeat 0, basic rate income tax. And that this would apply across the NHS, across the private healthcare sector, across the social care sector. It would not apply to agency staff. We need dedicated, loyal staff back in the NHS, back in private healthcare, not, in a sense, on a temporary basis within the agency staff community. And this proposal should apply to UK staff only, so people currently living in the UK. The top rate of tax would still apply to those earning above the top rate threshold, just over £50,000, but those staff would also benefit from a zero basic rate income tax band. So that will be good for GPs and consultants and surgeons who also are leaving the trade because they feel sometimes it's just not worth it. We believe that this bold, imaginative proposal would benefit some 2 million frontline, patient-facing staff in the NHS and social care. The other key thing is that we've got to buy more private healthcare use, operations, capacity by the NHS within the private healthcare system. And indeed, as was done 20 years ago by the Labour Party, when they got waiting lists down to very low levels, overseas if required. Now you might say, well, that's all very well. How much is that going to cost? Well, I'm setting out here the broad numbers as to what that would cost. And then, of course, we're going to set out how we fund it. Social care staff. There's well over 1 million social care staff with an average salary plus or minus 25,000 a year. Paying zero basic rate income tax would save them almost £2,500 a year. That's a very significant increase in their net take-home pay. Tax foregone to the Treasury, just over £3 billion. The same is true of healthcare staff. Some 750,000 frontline, patient-facing healthcare staff, with an average salary of around about, let's say, £34,000. That's over £4,000 increase in the net take-home pay for frontline NHS staff on that average salary. That's actually a better deal for nurses than they're currently asking for in the nurses' strike. So just think about that. This has the potential to resolve the existing strikes and to retain staff and attract staff back into the system. So the tax foregone by the Treasury there would be, again, just over £3 billion. So we're talking about just over £6 billion. Now, of course, it's hard to get to the exact numbers. So I've added a significant contingency of another billion. Total tax foregone, £7.3 billion. Then obviously we want to attract, let's say, another 150,000 staff, an average salary of 30,000. That's another £4.5 billion. These are, of course, big numbers. But the first thing that happens is there'd be a massive saving on agency staff who would come back into the system. We think that would be in the order of £1 billion plus. There would also be a significant saving on the benefits bill. Many people who've left the sector, who've gone on to benefits, who are trained, we think would be attracted to come back into the system. That could be another £1 billion a year. So when you take the cost, you knock off those savings, we're talking about a net cost, £9–10 billion a year. But I haven't finished. Because the truth is that I think the NHS is going to need to buy in the order of 3 million operations. £3 a pop, that's 9 billion. The sums are big. But I'm going to tell you how we fund it. So the total cost to get to zero waiting lists after about 2 years, it's around about 15 billion a year for 2 years. But we have to do this. We have to be bold. We have to target something that's really challenging, that people treat as a national endeavour. Zero waiting lists in 2 years. To bring us in line with what people expect and demand and get in other Western nations. I'll give you an example of how extraordinary it is. I was in Australia recently, giving a speech to a bunch of sort of political folk, and I talked about the government's pride in announcing a target of 14 days to see a doctor. They laughed at me. They thought I was joking. 14 days, they said. In Australia, if you couldn't see a doctor in a day, there'd be riots on the street. That's how low our expectations have gone. It is simply not good enough. We have a national health emergency. We have to be demanding, but to get to zero waiting lists, we have to be bold. We have to think big. We have to think about a national endeavour. And we have to go for it. Now, before I go to the cost of it, the funding of it, you might say, well, that's all very well and good, Richard, but who actually believes that this could work? Who in the sector thinks that this is doable? And so I'm delighted now to be joined by Professor Carol Sikora, an oncologist of some 50 years standing, a former director of the World Health Organization Cancer Programme. Carol knows and understands how some of the key health issues work and operate and the challenges in the system. So, ladies and gentlemen, I give you Professor Sikora.
Thank you, Richard. You know, I've been qualified 50 years this year, and I've been a consultant 44. I was very young when I started. I'm now very old. That's how it works. But, you know, I've been through 19 of the 23 reorganisations of the NHS in my own professional career. The last one, believe it or not, has gone without trace. Gordon Messenger's report in February and March of this year on the NHS just disappeared. No interest in it whatsoever. And I think some of them have had profound impacts. The only one that survived my career is the big building of district general hospitals, and that's all that remains. The problem we've got now is there is an emergency. No one believes me. I've been ranting along on Twitter for the last 2 years about the emergency in cancer, which is my specialty, and no one sort of believes it. And what you've got here is a plan. It's an idea. I only heard about it on Thursday, and it's actually grown on me over the weekend because I can see all sorts of ramifications, attracting staff back from agency, giving something even to the senior people because they'll get that little tax break. For them it's a small bit, but and as Richard says, why would the nurses go on strike if they get that? They're going to get more than the 20% overall back to them in their pocket. So it does seem like a radical idea. And it's not party political, it's not left, it's not right, it's just a sensible thing to do. I've read various reports from think tanks, from the NHS Confederation about the NHS, and they're all wishy-washy, the same stuff, more of the same, more money, another 10 billion. It's all wasted. That's not how it can work. It's got to be some bold scheme like this. I don't understand money, that's my problem, but I can see this could work. And just to go back to something Richard said, I was in the Cabinet Office a long time ago, in the year 2000, when we came up with a 2-week wait for cancer. It was the Expert Advisory Group on Cancer. Tony Blair was there. He had lasted about 5 minutes and walked off. And we came up with a 2-week wait because there wasn't the capacity to see cancer patients diagnosed by their GP in quicker than that. So when I went to conferences in Europe, like Richard in Australia, people laughed at you. Said, what do you mean? You know the patient that got cancer? You really think the patient that got cancer? And you make them wait 2 weeks before they get any investigation? I said, yeah, well, that's because we'll get there in the end. The year 2022, only 65% of patients referred under the 2-week wait are being seen within 2 weeks in the NHS. If that isn't a crisis in my specialty, what is it? We know early diagnosis means good results, late diagnosis means bad results. So delighted to be here, delighted to hear the plan. I hope it gets to fruition because we definitely need to do something really drastic for the NHS. Thank you, Richard.
Thank you very much. Carol, thank you so much for that. I really do appreciate it. Now, before I talk about how we're going to fund it, I just want you to imagine for a second, I know it's a bit strange, imagine that I'm the Governor of the Bank of England. I pick out of my pocket a £20 note. In fact, actually, I go to my home printer and I print a £20 note and another one and another one, and I give every £20 note to each of you in this room. The truth is, it's not your money. I printed it. I'm the governor of the Bank of England. So if I've given you that £20 note in order to add to the money circulating, why would I then, having given you that £20 note, why would I pay you interest on the money that I've just given you? If you had a £20 note and you gave it to me to look after for you, as the sort of the most secure place to keep it, then sure, it's your money. You'd ask me to pay you some interest. But if I've printed it on the home computer and just given it to you to help the economy, why on earth would you demand interest from it? Why would I give you money and then pay you interest on the money that I've just given you? That, ladies and gentlemen, is the nub of what is going on at the moment with all of what's called the Bank of England's quantitative easing. So here's how we fund this solution. Currently, the QE debt, the quantitative easing debt, is around about 850 billion quid. I mean, these numbers are just off the scale. It's impossible to imagine. But what we've got to do is we've got to redesignate all of that QE debt that sits on the Bank of England's computer. Remember, they literally just printed it on their computer and sent it around. Redesignate it into 75-year warlike corona bonds. Fix a nominal rate of interest on it of 2%, and then you tell the whole market and you tell everybody it's staying on the computer for 75 years. It'll deflate away into nothing. We'll all be long gone. You confirm to markets that you're not going to try and sell any of this debt back into the markets in a process that they're currently doing, unbelievably, called quantitative tightening. So the Bank of England is currently, just a couple of weeks ago, they sold 750 million of this QE debt back into the markets. The markets know the Bank of England is a forced seller, so guess what? The market is demanding a higher price. But if you starve the market of debt by saying we're not going to sell any of this back into the market, we're going to leave it on the computer for 75 years, then the rate of interest goes down. So what the Bank of England is currently doing is totally and utterly counterproductive. It's actually helping force interest rates higher. The next thing is that, unbelievably, the Bank of England is indeed paying interest on all of the money that it printed to the commercial banks. Now, you might say, well, what are the rules? What's other central banks doing? I can tell you. Guess what? The other central banks are not doing what our Bank of England is doing. The ECB is not doing this, and nor should the Bank of England. It is literally, because interest rates have gone up, it is a transfer of wealth from all of us taxpayers to the city investors, the city banks, the city institutions. They didn't expect this windfall profit. It wasn't their money. They didn't earn it. They didn't make a decision, we've got a whole load of our own money that we've earned and we're going to lodge it at the Bank of England. No, the Bank of England printed it and pushed it into the system. I go back to my £20 example. Why would you pay interest on money that you printed? You shouldn't do. So that is absolutely critical. The Bank of England is making a serious mistake. And it's costing, depending on the level of interest, it's costing the taxpayer between 20 and 40 billion pounds this year. So I go back to the cost of our proposal, about 15 billion each year for the next 2 years to get to zero waiting lists. But the Bank of England wrongly has made a decision to send 20 to 30 billion, depending on interest rates, of our money to rich city institutions. So the taxpayer is being impoverished and the already rich city institutions are being enriched. And as I say, it's in the order of 20 to 40 billion pounds a year. Now you might say, well, you would say that, wouldn't you, Richard? You know, you're trying to criticise the government. If you don't take my word for it, take the word of some of the finest economists in the country. People like Jeremy Warner has written about it in The Telegraph, fine newspaper. People like Liam Halligan from the same newspaper has also written about it. Patrick Minford. Other economists around the world are writing about exactly the same thing. If you don't trust the economists, what about a former deputy governor of none other than the Bank of England? Yes, Sir Paul Tucker. He's also said it's completely wrong to do this. He thinks the number's even bigger. He thinks it's 30 to 45 billion pounds a year. Normally I'm the optimist. And yet, the chief economist at the Bank of England is saying, no, we've got to do this. He's saying it would amount to an effective default if we stop paying this interest. He is completely and utterly and totally wrong. Totally wrong. A former deputy governor of the Bank of England says we shouldn't be doing this. Other central banks around the world are saying we shouldn't do this. So what I say is we've got a bold proposal to help get to zero waiting lists. We've got a national health emergency. This is a solution that can help attract staff back into the social care service and also the National Health Service. We can retain staff. We can use whatever capacity that the NHS can buy to get operations done, to get that list down, as much private healthcare capacity. Whether it's 15 billion, you can argue about, sort of nickel and dime it, whether it's 14 or 17. What I've shown you today is that all of this is fundable. It can be paid by stopping the completely wrong and erroneous decision by the Bank of England to pay interest on its reserves to rich city institutions. And I say that the Chancellor and the Governor have a simple decision to make. Now, some will say, hang on, but the Governor of the Bank of England is independent. How independent were they when they took the decision to print 400 billion quid during the COVID crisis, when they knew there was a crisis? They did that because, quite sensibly, at the time, they realised there was a crisis. And the truth is that the Bank of England, even when it's independent, liaises with the Chancellor of the Exchequer. So they can do this. They could literally make this decision today. They could make this decision because the question for them is, do you want to continue to unnecessarily enrich city institutions, city banks, rich investors for the QE money, for the interest on money that wasn't theirs in the first place, that was printed by the Bank of England? Do you want to continue to do that? Or Jeremy Hunt, Andrew Bailey as Chancellor and Governor? Or do you want to play your part in helping provide the funding to help resolve our national health emergency? Literally at no cost to the taxpayer. That is the choice. I say to you, in summary, we can solve the strikes. We can get the lists down to zero. If it's 25 months, 23 months, it would be a fantastic achievement. The nation would demand that we keep them there. Quite rightly. So the choice is there. Chancellor and Governor, you can do this. You can help solve our national health emergency. We've got a bold solution. And of course you can say, well, that number's right and that number's wrong, fine. But no one else is coming up with a big, bold, radical solution and a serious ambition to get to zero waiting lists. Zero basic rate income tax for all frontline, patient-facing social care workers, healthcare workers. Just think what that would do. I believe, we believe at Reform, that that is an achievable target. It requires courage from the Chancellor and the Governor, but this is doable. And I say to you, let's demand that they make this decision, and then we can target zero waiting lists, we can get more staff, into our social care system, our healthcare system, and I commend this plan to everybody. Thank you very much. Now, in our presentation, we have got some appendices with various bits of data, just talking about how the growth of the waiting lists, just over a million increase before the pandemic, since 2015, proving it's not just the pandemic. There were fundamental flaws, and then the rise since then, and then comparatives between the UK and other nations, doctors per thousand, nurses per thousand. This is OECD latest data, hospital beds per thousand, as well as the amount of spending on healthcare. So the data's there, the solution is there. I've shown how we can fund it, and I'll take any questions. Great. Thank you.
Pleasure. There you are, sir.
Hi, Jude. Chris Oak from Telegraph. Did you say there that there'd be zero income tax for healthcare workers? I missed that point.
Yes, that's the whole crux of it.
Yeah.
Lovely to see you. The whole crux of it is that all social care workers and all healthcare workers who are frontline, patient-facing, so not the administrators, not the managers. I suspect there might be a bit of a scramble from some of the managers who were previously trained who might want to go back in the front line. That's the whole point of it. Yeah. We want more people on the front line, and in the nicest possible way, less people in the back office.
So no income
yes,
tax.
there would be no basic rate, Chris, of income tax for everybody on the front line. And again, that's social care and in the NHS and also in the private healthcare system. But Chris, it wouldn't apply to agency workers. I repeat that, because we want people to come from the expensive agency workers back into the main system.
Forgive me for this. I'm sorry if I missed it. How many would that be, and how much would it cost, that single measure?
So, social care staff on slide 3 is about 1.25 million staff. The benefit to the individual for someone on an average social care staff of around £25,000 would be just under £2,500. Total cost to the Treasury, 3.1. Give or take, healthcare staff, give or take £750,000. And that would be just over £4,000. So the total cost plus contingency plus the extra staff, you're looking at a total cost of 9 to 10 billion a year. And then on top of that, we've got to use private healthcare capacity, possibly overseas capacity, to buy operations in order to get down to zero. All right? But the point is, if it's 15 billion a year, it's easily fundable if you change the way the Bank of England is paying interest on its reserves, on this QE debt. So it's a bold, completely innovative solution. No one else has talked about this. But we think that the crisis is so great, the emergency is so severe, it needs this sort of solution.
Hi, Patrick O'Flynn. I'll ask a supplementary, if I may, later on about something else, but to address the policy you've unveiled today. On the funding side, some people might say it all sounds a bit kamikaze. You claim to be able to solve this enormously expensive provision of public services, and the shortfall quotes at no cost to the taxpayer, simply by sort of redesignating bits of funny money, but that's the funding side. On the spending side, the phrase that keeps recurring in my mind is deadweight cost, which you'll know from economics. You're actually proposing to give maximum tax cut to the best paid people in the NHS. They're the ones who would get the full benefit of zero rate, if you let me finish, zero rate standard rate income tax, because they pay right up to the 50,000. The average care worker, you're saying, is saving 2 and a bit grand. I reckon the average consultant, that's a 7 grand tax cut, and they're probably the least likely people to dob out of doing their jobs in the first place. And also, you say you're going to use some of the money to buy 3 million extra operations from private healthcare. Well, who do you think does the operations, right? It's largely the same consultants who work for the NHS. So you're going to be basically robbing from Peter to pay Paul, as you're taking away NHS capacity to pay top dollar to private care providers. That's not going to solve your expert capacity constraint at all. And, you know, the brutal truth, isn't it? If people go into the next election thinking the state of the NHS, the disastrous state of the NHS, is my number one issue, that's the thing that's really going to swing my vote, in the real world, they're going to vote Labour.
Look, great questions, Patrick, and I will pick them up one by one. On the funding point, look, as I said, don't trust me, trust the former Deputy Governor of the Bank of England. I'm being more cautious about the potential saving than he is. Trust the economists who write for some of the finest newspapers in the land. Trust economists from elsewhere in the world who are also writing about this, aghast at what our Bank of England is doing. So don't trust me, trust the other experts, former Deputy Governor, other economists who are saying exactly the same thing. And yes, you're right about the issue of the staff, but we've got to retain everybody, Patrick. We've got to retain the GPs who are exhausted, tempted to leave the system. We've got to retain the consultants because it's absolutely vital. It's staff required at all levels. There's no point having the nurses if the surgeons have legged it. And we've got to also attract them back into the system. Recently retired surgeons, specialists, consultants. We want them back in the system 1 day, 2 days, 3 days a week. Because all of a sudden they say, yeah, this is a national endeavour and actually it's worth my while paying it. So I want people across the whole system. And yes, you're right. You could say it's a blunt instrument. The crisis is so grave, sometimes you've just got to be a bit bold. You've just got to go for it. But here's the other point about your issue about, well, you're robbing Peter to pay Paul. I'll tell you why you're not. Because I speak to consultants who say when they do exactly the same operation in a private hospital, they'll do 3 in the morning. The following morning, they go to the NHS theatre. They don't do 3 in the morning. They do 1. They'll be lucky if they do 2. Never 3. So that absolutely proves why you're not robbing Peter to pay Paul. Do you know what? Competition is a good thing. If you increase competition, you drive up standards, you drive down the price. What will happen here is that extra healthcare capacity will appear all over the place. That is a great, great thing. Now, others in other parties will say, oh, that's a terrible thing. The most terrible thing is that we've got a healthcare emergency. We've got at least 7 million on waiting lists, probably way more, and we've got a solution to it. And I want competition. I want private healthcare to be as efficient as possible because that will actually help the NHS. It'll relieve pressure on the NHS. It's a fantastic thing, not something that you say is robbing Peter to pay Paul. I don't know if I've answered all of your questions, but I've given it a go.
Yeah, okay, so can I ask the quick supplementary, which is, I concluded my question by saying in the real world, if people really want to vote on the state of the NHS, they'll vote Labour at the next election. Isn't it true that the issue upon which reform stands the greatest chance of attracting votes is immigration, both legal and illegal? So first, what do you think of the Centre for Policy Studies report today with recommendations about combating illegal immigration, particularly in the Channel dinghies? And secondly, why doesn't Reform have a migration spokesman, and don't you think you ought to get one?
Great questions. Look, where's Labour's big bold plan to solve the emergency in the NHS? Where's their ambitious plan to get to zero waiting lists? Has anyone heard that from Sir Keir Starmer? I haven't. Yes, they talk about training. He talked about it this morning on a certain programme. They talk about training staff in the future, but that's years away. Years away. We need to do this now, and this is the only solution that anybody's come up with that will retain staff and that will attract staff back into the system. And you're absolutely right about the issue of immigration. It's a massive issue for everybody, both lawful and unlawful, illegal. And part of this policy is that this would apply to people currently living in the UK. We've got 5.3 million people on out-of-work benefits, a number of those will have come from the social care or healthcare system. We want them to be attracted back into work, back into helping with this national endeavour. And I've said very clearly, and the reason, frankly, Patrick, I am the migration spokesman because this is so important to everything we do at Reform UK. We've got to make our economy work for British people. Everybody talks about productivity. It's very hard to know what that really is. I'll tell you what's unproductive. 5.3 million of our own citizens on out-of-work benefits. That's what's unproductive. 1.5 million more than pre-COVID. If we got those people back into work, rather than doing what the CBI want to do, rather than doing what big bosses want to do, which is to import cheap, low-skilled overseas labour, we get those people back into work. We save 20 to 30 billion quid a year. Serious money. Another way of paying for these costs. So yeah, from top to bottom of Reform UK, the whole issue of lawful immigration and controlling it and having a zero illegal immigration policy, that is absolutely central to what we do. We announced a 6-point plan a couple of weeks ago on this, and it's interesting, isn't it, that you saw headlines yesterday in, I think, the Sunday Times from various ministers in the government. Funny how all these headlines were exactly what we were proposing in our plan. Funny that, isn't it? We're rising in the polls. The government, the Tories, are falling in the polls because we've got the right policies. And the truth is, we've heard this all before, through Home Secretary after Home Secretary after Home Secretary. Nobody believes it from this government. We have to get to zero illegal immigration. And actually, you see, healthcare is absolutely fundamental. And in a sense, we have been reliant on skilled overseas healthcare staff. But there's a real moral issue about taking trained healthcare staff from developing nations when we're not training our own people. We've still got a cap on training doctors. It's absurd. It's even worse now because of that cap. What's happening is the universities are saying, well, I want to train more international students in healthcare. And so what they're doing is they're actually reducing the number of UK people being trained in favour of more international students who then get their degree and then go overseas, go back home. So it's even more counterproductive. So the answer, Patrick, in a sense, I think what many people would like to get to is a double zero. But the issue is that actually it's healthcare that is the crux of our biggest challenge, which is why this policy is so vital and I think provides a real chance at a solution. I hope that helps. Karen.
There's no doubt that this would be a powerful incentive for people doing overtime. And that's what we have to do for the emergency. To clear a backlog, you have to have people doing work they don't normally do. So Saturday morning, Sunday working, doing 8 eye operations, 10 brain operations, all this sort of thing. You just do that. Scans and so on. So the people that you need for that are not the consultants most of the time. You need people to staff the theatres, to get the scanners going and so on. And this would be a powerful financial incentive to get them back on a Saturday. That's how I look at it.
It's fantastic. It's exactly right. We've got to use our physical theatre assets, our diagnostic assets, and the people in order to provide extra capacity. And actually, it doesn't matter where that capacity is. We did poll it. 81% of people don't mind who provides the care. They just want the pain gone, the agony gone, and the problem sorted.
Thanks, Richard. Ben Quinn from The Guardian. I was just 2 questions for me, and I was trying to put myself in the shoes of an average voter, maybe who, like me, is not as economically literate as you are, and they might look at these clever slides and the clever shuffling of money, and the thing that comes to mind is the recent experience of the Liz Truss approach to economics, where you leave things sitting on the computer, quote unquote, as you say there, for another day. Do you have a concern that people would have a terrible feeling in their feeling of foreboding in their mind that it's a retread of that approach? And the other question is, I wonder if you'd comment on the you'd speak to the question which people might have, that ultimately this is a way into moving away from the basic structure of the NHS towards a privatised US-style approach to healthcare, and whether you maybe you feel that's a good thing. And perhaps this is one for Professor Sikora as well, who I think, Professor Sikora, you're on the record as describing the NHS as the last bastion of communism. So, I mean, and I wonder if you still feel that way about it, and perhaps if you agree with Professor Sikora in that analysis. I say that, by the way, as somebody who has been bereaved as a result of cancer, and thank you for all the work you've done as well. So it's not a personal one at you at all, but yeah, if you could speak to any of that ramblings, please do.
No, look, great questions, and I do appreciate it. The complete flaw in the Truss Kwarteng brief tenure was that they didn't explain, and they just talked about cutting this and this. They didn't explain how they're going to fund it. So what I've clearly laid out is I've laid out the problem, the cost, and then I've laid out how you fund it. And you've got to explain it and explain it and explain it. Now, you might think, as someone else suggested, that it's sort of funny money. But as I say, don't trust me. Trust a former deputy governor of the Bank of England. Don't trust me. Trust other central banks around the world that are not doing what our central bank is doing. Don't trust me. Trust other bright, serious economists who are some of the best in the country, if not the world. Indeed, economists around the world are writing about this, are writing what on earth is the UK Bank of England doing? And the numbers are huge. And I know it sounds a bit glib, but in a sense, there's a huge margin over and above the cost of what we're proposing that could be resolved by this. In fact, the number's so big, you could say, well, maybe there's a halfway house. Someone might say at the Bank of England. But the reality is, this is doable. I know it's doable. Sir Paul Tucker knows it's doable. Other economists know it's doable. And we're all wondering, why is the Bank of England and the Chancellor allowing the taxpayer to be impoverished, not just this year, but next year and the year after and the year after, to enrich city banks? It's not right, it's not necessary, and it's actually preventing the improvement of millions of people's health in this country. Now, you quite rightly say, well, is this a way to privatising the NHS? No. What it is about doing is increasing capacity. It's about bringing agency staff back into the NHS, where they can benefit from feeling part of a team. I talk to people who say the thing about agency staff is, yes, they're trained, but they don't have quite that sense of loyalty and part of the team if you're employed full-time or part-time in the NHS. So actually, it would enhance the NHS. But look, we have to be honest. The NHS may be the most loved healthcare system in the world, but I don't think anybody's claiming it's the best managed. And actually, a bit of competition is a good thing. And the health emergency is so great. It's so urgent. We can't wait for puritanical ideological debates about this. We've just got to get it sorted. We've just got to get it done. And it needs to be done now. And I think my polling, 81%. 81%. They don't care who does it. Just get it done. Just get the pain gone. Let's have all the ideological debates later. Let's get this problem sorted now. Then when you get to zero, what will happen is the people will say, thank God for that. Right. Now, can we make sure that it stays at zero? And what do we need to do that? And I think that's for the national interest. Let's have that debate, but the first thing is, let's get there.
Carol, did you want to respond?
Yes.
No, I think I don't understand the economics, I can't pretend to, but it does seem a way of, first of all, admitting there is an emergency that's not soluble by just letting it drift, which is what both main parties seem to be wanting to do. And secondly, it's the actual... The mechanism of it seems very attractive, and it does grow on you that it could be implemented. Okay, there's lots of details. Like people like me in my past career had management role and a clinical role. How would you sort that out and things like that? But it's easy to identify people. It's really aimed at the key workers who are not the doctors, in fact. They're the technical staff, the cleaners, the technicians, the care staff, and they're the ones in that low bracket that would get the most out of this. And they would be incentivized to work extra to clear the backlog. So I think it's worth a try. And I hear the problem about consultants. If you contract out to the private sector, the consultants have got to come and do it, and they get paid more. But, I think overall you can increase the capacity, which is what's needed, because a backlog, by definition, needs a short-term action, not a long-term plan. But as Richard says, when you get to the end of the backlog, people may say, well, that was actually rather good. Let's see what we can keep in it and go forward.
And there'll be lessons learned. So there'll be things that get right and you can improve. If you believe in continuous improvement, but actually more capacity elsewhere will help the NHS. It'll ease some of the pressures, some of the demands, some of the stresses on the system, which is why, tragically, great trained nurses and doctors are leaving the system because they're up to their ears in it. They're exhausted. So if you ease that pressure, then actually it can get better and better. And I think that's what the country wants.
Yes.
Last question.
Will Donnelly, a question for you on the cost side of things. So the first two bullet points here on social care staff. So the first one, a saving of £2,486 per year, on average £25,000 salary, equates to about 10% in terms of salary. And then for healthcare staff, £4,286,000 on a £34,000 average salary. That equates to approximately 12.5%. I mean, that's approximately
the net number.
Yeah. So that's the current.
So that's the net saving. That's the extra money.
Correct.
They get in their bank account. That's the net increase, which is obviously very significant.
And that's the 12.5% figure is very similar to the current level of inflation. The Royal College of Nursing are currently looking for a pay increase of about 18%. 19% even. How do you think? Do you think this would be acceptable to the Royal College of Nursing?
That's a gross number. So if your salary goes up by, let's say, they don't expect to win that. Your salary goes up 15% gross, net, you're going to be obviously a lot less than that. That's the difference. The other benefit of this is that actually this proposal, which I think will be very attractive to staff and indeed to the unions, is that actually it's less inflationary than by increasing the gross number. And that's also very important. I know we've slightly overrun, but it is important. Thank you very much, everybody, for coming, for your questions, for your interest, and do get in touch with us in the future. Thank you very much.